everybody accept the hello?
Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
Okay, great.
Good morning, sir.
Good morning. Okay. Hello?
Sir, just a minute. Actually,
Okay.
Dr. Priyanka is having issue with joining. Just give me a moment.
Okay, no problem. Rajan has joined?
ना शायद देखा तो नहीं सर वो रिंग मारू तुमने.
Okay. Vineet has joined?
Yes, sir. Good morning, sir. I'm here.
Okay.
Vineet has joined.
Yes,
Dr.
sir.
Priyanka will also join in a moment. Rajan Bhaiya.
Good morning, sir. I have joined,
Good
sir.
morning.
Good morning,
You are
sir.
joined. Okay. Dr. Priyanka Rai, she is from RML Lucknow, Professor Surgery. Thank you, ma'am, for joining.
Thank you so much, sir.
Dr. Srinivasan is joining?
એમણે કીધું તો છે હું એમને ફોન જ કરું છું. રાજનભાઈ ફોન કટ કરેલો મને લાગે સાહેબ જોઈન કરતા જશે.
I have already joined.
ઓ
Great.
સાહેબ ગુડ મોર્નિંગ સર. સોરી.
morning.
Good morning. Morning.
બસ એક આ શ્રીનિવાસન સરને એક રિંગ મારી જવું છું.
Okay, sure. Let us start then.
યસ સર.
And introduce everybody. That would be the great thing.
યસ સર. જસ્ટ give me a moment.
No problem. It's okay. Good morning, Rajan.
Good morning, Sahib.
સર શ્રીનિવાસન સર જોડે વાત થઈ. એકચ્યુઅલી હી ઇઝ ઇન અ રિમોટ પ્લેસ. મને કે કદાચ ઇન્ટરનેટ સ્કેચી છે. હી વિલ ટ્રાય ટુ જોઈન. Good morning, everybody. Respected teachers, colleagues, and dear friends. We are here with a second case of inguinal hernia presentation. With us today we have Dr. Srinivasan. He'll be joining probably. He has some weak internet problem. He is a professor of surgery at Coimbatore. Then we are joined by Dr. Rajan Patel, who is a PhD in hernia and a professor of surgery at NHL Medical College. We have Dr. Priyanka Rai, who is a professor at RML Lucknow, and Dr. Vinit Chauhan, who is an associate professor at BJ Medical College. I am Dr. Apurva Shah, and I have my guidance and moderation of the whole this session, Dr. Pankaj Modi sir, who is a professor of surgery at BJ Medical College. This is a virtual presentation of the same exam scenario that our students undergo every year for their annual exams. So the idea is to ask him to continue till the history part first and then the examination part. We try and not interrupt him in between unless he makes a gross mistake. And we see to it that the clinical part is very well assessed, followed by the investigation and the treatment part. Sir, shall we start?
Yeah, just a minute, 1 or 2 points for all the examiners. So give more importance to clinical questions because this is a more or less clinical case. So we will stop him after history and summary of history, followed by after completion of that questioning, we'll go ahead with the examination, then again question. Investigation part is fine, but I would just request all the examiner to ask and clarify the query of students about particularly because that is a going on controversy, open versus laparoscopy, and even in laparoscopy, various type, TAP, TAPP, ETAP. So we should ask him the question, but let him be clear what he should answer when the questions are asked regarding what surgery you will do like that. So that is the practical part and theory part at the time of management. Madam, I think that should be the okay because that student should go after this, that what he should answer. That means the question will be what will be the gold standard, what you will do when your turn come like that. Those kind of questions are commonly asked in exam. Okay, so without wasting any other time, Apura, should we proceed with that? Okay, Smith, let us start.
Yes, sir. Good morning, sir. Good morning to all. I am Dr. Smit Patel, third year general surgery resident from the BJ Medical College, presenting here the case presentation of the inguinal hernia under guidance of Dr. Pankaj R. Modi, sir, our HOU and professor, Dr. Apurva Shah, sir, my HOU and professor, Dr. Vinit Chauhan, sir, associate professor, and Dr. Maulik Mehta, sir, associate professor. A 70-year-old male patient working as a farmer came to Civil Hospital Ahmedabad with the chief complaints of swelling in the bilateral inguinal region since last 6 months and pain over the right side swelling since last 1 month. Patient was relatively asymptomatic 6 months ago. Then he noticed swelling over bilateral inguinal region, which is insidious in onset, gradually progressive to current size. Swelling increases on coughing, straining, and weight lifting. Swelling decreases on lying down, associated with the complaints of pain over the right side of the swelling since last 1 month, which is dragging in nature, non-radiating, increasing with a straining and relieved on the rest. There is no complaints of fever, nausea, vomiting, no complaints of abdominal distension. There is no history of chronic cough, no history of constipation or urinary complaints, no history of irreducibility. Patient having no history of diabetes, hypertension, tuberculosis, no history of any previous surgical intervention. Patient on personal history is on mixed diet, appetite is normal, bowel bladder habits are normal. Patient having addiction history of chronic BD smoker, 10 BDs per day since last 14 years, no significant family history. So a 70-year-old male chronic BD smoker working as a farmer presenting with the chief complaints of bilateral inguinal region swelling since last 6 months, gradually increase in size and increase on coughing and straining and decrease on the lying down associated with the right side of the pain since last 1 month.
Okay. Smith, anybody would like to ask Rajan Bhai? Madam?
Yeah.
Ma'am.
Yeah.
Hello,
Yes,
Yes,
Yes, sir.
Yes,
please.
sir.
Dr. Smith. You have told there is a bilateral inguinal swelling. So both the swelling patient has noticed himself or someone has give her his attention, because to know the both the swelling simultaneously is little bit not easy for patient. So someone might have noticed and tell him that bilateral swelling may be there. So what is your history is?
sir. In my case, patient is not has noticed his swelling, sir, incidentally, sir.
Okay.
Sir, I
So
want to
any of the side which is larger or smaller he noticed, and later on any swelling come more on the either of the side.
Sir, the swelling is the right larger on the right side. So and patient have his bilateral swelling. He noticed bilateral swelling simultaneously, but the swelling is larger on the right side.
That is
Madam,
what
you
patient's
wanted to,
complaint.
sorry.
Yes, sir.
That was the patient's complaint.
Yes, sir. Patients complaining at that, sir. He had noticed the swelling on the bilateral side, but on the starting of he noticed the right side swelling is more prominent than the left side.
That should be a part of your history also, because any complaint which is prominently noticed by the patient, then you have to mention it in your complaint also. The right side
Go to
swelling is
ODP. Have you
bigger.
mentioned it, Smith? Go back to ODP. Yes.
No, sir. I don't separately
No,
mention.
he has not mentioned, sir.
So that's what I wanted to say. Understand this point. You should say patient notice swelling simultaneously, but more on the right side, like that.
Yes.
And you have to separately, if it is that, you have to describe both the swelling separately. This has appeared first, this has appeared later on, this is a lateral size. If at all it is insidious on notice bilaterally, then also when he noticed right side was predominant, left side was smaller one, and both are having a different reducibility. If it is noticed, then it has to mention separately. Otherwise, it's okay.
Okay, madam, you wanted to ask something?
No, sir.
Okay.
Sir,
So,
I
Second
want to,
question
I
is,
want to, sir, I
my
want to,
question is, second
Huh.
question is, you have told about no complaint of fever, nausea, vomiting. Vomiting we understand, nausea we understand. What is the relation of reducible swelling with fever?
Sir, fever, I ask for the, sir, any feature to rule out the features of any irreducibility, or sir.
You have already mentioned that there is no
Yes, sir.
history of irreducibility.
Yes.
History itself you are describing it as reducible swelling. So this part is not necessary. Fever complaint is not necessary with this. Last you can mention abdominal distension in chronology, it is earlier, that is fine. Reducibility, that is fine. But fever is nausea doesn't come early in the history presentation. That has to, if you want to complete the history, you can mention it in the last part.
yes,
Pardon,
madam.
yeah,
Yes,
pardon,
ma'am.
sir. I would like to ask one thing, sir. That earlier when we used to mention about history of present illness, we were asked to write in the in patient's own language.
Yeah.
So whether it should be written like bilateral swelling over bilateral inguinal region, or lower abdomen, what they can write. I just want to ask, sir, this thing. This was my query, because when we mention history of present illness, it is clearly mentioned that it should be in patient's own language.
Right. Okay, Smith, have you got the?
Yes, sir.
Did you get the question?
Yes, sir.
Okay.
So you should not mention the inguinal region. You should
Yes.
say the bilateral groin region or lower abdomen.
Yes, sir.
Okay. So, Smith, that brings to me one question. What is definition of inguinal region and what is definition of groin?
Groin.
Groin region is the region includes the, sir, above and the part of above and below the inguinal ligament, where when we flex the thigh, there is a part of the lower, the part of the lower abdomen and part of the thigh which touches each other. It is called as a groin region, sir.
Smith, by definition, madam, question is very valid. You should say groin rather than inguinal, because groin is 4 centimeter on either side of inguinal ligament. And when patient doesn't know that it is above inguinal ligament or below inguinal. And you are also not sure. So better word is a groin. Inguinal suggests above inguinal ligament and the thigh is lower down. So better word is groin. That's what you should know. What is definition of it? Because when you say groin, it may be femoral, it may be inguinal, it can be like that. That is the basic idea. Vineet, you wanted to ask something.
Actually, I wanted to point out the same thing as Dr. Priyanka, that we should not use the words inguinal. We should use groin. That's what I wanted to ask.
Yes. So, Smith, from all this, what you should have said is patient was relatively asymptomatic before 6 months. Then patient noticed swelling in a both groin region, for more on a right side than left, and describe right side, describe left side, like that. Why is it necessary that both sides should be separated and right side should be described first?
Because sir, right side is a prominent side, so it has to be discussed first. And the features of the swelling, like the reduced solubility, cuffing, and increase in size on cuffing and staining, should be described separately.
Okay, so patient has a large swelling on right side, small swelling on a left side. Which side pain is more likely?
Sir, due to towards the larger side of the swelling, sir, pain is.
That's so. So what
What
was
is-
the need? Yes, please.
What is the basic reason for developing pain for last 1 month in this patient? Can you able to attribute any cause?
Sir, maybe there is due to enlargement of the swelling over the right side. There may be neck compression of the compression of the neck of the sac. Maybe there is staining activity.
Smith, you are making a mistake. What are the various types of pain that you can have in hernia? Especially when you say a large swelling, what type of pain it will have?
It will, sir, dragging type of pain, sir.
So that is one. And a PRM sir પૂછી રહ્યા છે, that is a small hernia. What type of pain do you expect?
It is a dull aching.
No.
Rajan is also asking indirectly same way.
Same
Why
thing.
pain is more in last 1 month? Rajan, please explain to him.
So most probably he may have a strenuous work and breakdown of the muscle on that part will be more. And that may be the reason of developing a pain. Or he may not have noticed, but there may be increase in the size on the right side more now than the left side. So that is the breakdown of the muscle gives some kind of a pain. That's what I believe. Because when hernia develops, at the beginning, at that time, the dragging type of the pain had developed. And now it is after 6 months, in last 1 month, it has developed again. That means swelling has now started increasing the size again.
Apurva has asked very good question. What are the different type of pain? What my original question was, I might suspect patient might be having more pain on left side than right side. Why? It is in continuation of Rajan's question. So, what are the different type of pain? Because it's a pain. What type of pain? Once pain you have said dragging pain. Remember, the initially when hernia is developing, it will be dull pain, sometimes with the shooting pain of separation of or the breaking of the muscle. So initially when hernia is developing, that kind of pain is common. When hernia becomes larger or go on becoming larger, the weight of the content will cause that pain will be a dragging pain because the peritoneum does not have an actual pain. Please.
Gaurav, please mute yourself.
Gaurav, very busy person. Sorry. So that's what I was saying, that can be the fun kind of pain. Then the dragging pain because of the containing remain outside, particularly when patient walks. And that pain will increase as the patient continue to do exercise and swelling size to increase. Then there can be intermittent colicky pain. And yes, of course, pain of complications. That may be inflamed hernia, obstructed hernia, or strangulated hernia. But mainly it is a initial pain of separation of muscle, which will maybe dull or sometimes associated with severe occasional shooting pain, and because of the dragging. Okay. You said swelling decreases on lying down or disappears on lying down.
Sir, patient says that the swelling size is decreasing on the line. Okay.
So have you tried to clarify what is the difference?
Sorry, decrease in the lying down means the swelling is not completely disappears on the lying down. Whereas,
So what does it mean? I want to know that. What is meaning of that? It decreases size and disappears in size. Patient is 70 years of age. That is a hint for you.
so there is a defect in the weakening of the posterior wall muscles due to the aging.
No, that is fine. But what is decrease and disappears?
Decrease means, sir.
You said, no, you said, but what is in Smith? Here,
Yes.
somebody is asking you, so don't go on speaking
Yes.
same thing again.
Yes.
You have already clarified. Decrease means what? What I am asking you, what is inference of that? That's what the point here, what I wanted to say is when said it does not disappear completely, it may be indirect way. I'm not saying it is always. Usually at the 70 year of age, bilateral hernia, when patient die down, they disappears. Why? Because of the large direct posterior defect. That is the answer. Do you understand my question? That is what I want to say. So when you say decreases, it means patient is sure some kind of hernia remains. You cannot confine because it is a history, but just for the clarification. So use your word. If patient says disappears completely, use word disappears. If patient says some part of that, and you should clarify. Because does it disappear? You must not have clarified. Most likely disappears, not decrease. There is a significant difference because it is important. Direct hernia, usually when patient lies down, they disappear. And do they appear on its own? That's what you have said.
Yes, sir. On standing position, the swelling appears on its own, sir.
Where is it written or said? So you have said straightway said on cuffing staining. This is how swelling appears on standing its own without any further. That again suggests it is likely to be a large and direct hernia. You understand? So this is important. Straining comes later on. It may increase size. This from history, you can infer something about direct or indirect hernia. The point here, what I want to say is you ask a proper history. What is to be inferred from your history? Because most of the things you will find out from itself.
Yes.
Right?
Yes.
And do your patient is having history of coughing constantly?
No, sir. Patient don't give any history of sir coughing constantly, sir.
So then how can you say that the patient in history himself is telling it is increasing the size with the coughing? So what sir has told is whether it is increasing the size on standing and lying down, decreasing the lying down, that is more appropriate rather than to saying that it increases, because it is a deliberate questions you have asked for coughing only.
Yes.
So do you try to correlate your history to the textbook? It should not be the case. If patient doesn't have any cough, then how he is prominently saying that he is having increase in the size with the coughing? So this is contrary to the history.
So the point is that when it appears on its own, you can say that it increases on straining, or right? So have you said was there any history of irreducibility in past, in last 6 months?
No, sir. Patient don't give any history of irreducibility.
Okay. So then why did you ask no history of abdominal distension?
Sir, to ask sir to say the features of sir abdominal distension is a feature of irreducibility. To ask out and is there any
next slide.
But that's what sir is saying, that
yes,
there is no history of coughing you are mentioning in the history. There is no history of irreducibility. You are mentioning the history of distension, and that is also in the priority in the first or second chief ODP. So it should not be like that.
It should come earlier. Do you understand? Irreducibility comes.
That means your logical thinking of a case of a hernia is not as per the logic. It is as per the textbook you are going. So it should be as per for PGs, what we expect is how you are going to describe your patient in a patient's own word and find out the things rather than what textbook has mentioned.
Yes.
Okay.
Okay. So you should say irreducibly first, another thing. Why you have taken distension first? That's what I wanted to know. It is not that important history. It will become important if patient gives history of irreducibility or your hernia is irreducible.
Yes.
Do you understand? What you want to establish from ODP itself is that this patient has a bilateral hernia, probably direct, without any complication. That should be inference from history. And you should say no history of urinary complaint will also come earlier than constipation and chronic cough. Because why?
Because in the old age there is a
Not old age. Now there is nothing like old age. It is your patient. You should specifically say, as my patient is 70 years of old age. This is not a history theory discussion. We are talking about your patient.
Yes.
Suppose, Sumit, the patient of yours having a urinary burning, does it have any significance on hernia?
Sir,
Burning micturations for 3 days, 2 days.
sir, recent burning micturation, sir. We should ask about the other complaints also, sir. For
What
chronic
other
complaint to
complaint?
relation to the hernia, like sir, there is a frequency, urgency, or a poor stream of urine, or any complaint of nocturia present in the patient.
So simply writing a urinary complaint rather than you should mention that there is no urinary obstructive symptomatology. That will be more appropriate word because you want to attribute increase the pressure in the abdomen while micturation.
Yes.
Then one more thing you should keep, Smith. Mostly this will come as a short case. Keep this thing in mind. It is not a long case. Understand this point. So yes, you should be very precise what you are talking about and in a order. So irreducibility, urinary complaint precedes over distension, nausea, vomiting. You understand?
Yes.
That is the point. Okay. Anybody would like to add anything? Madam?
No, sir.
One more
No.
thing
Yes,
I would
yes,
like to
Ajay.
tell you.
Hmm.
When the patient is having history of irreducibility or a huge swelling, then constipation or distension should come earlier. But when it is completely reducible swelling, there is no point of saying that the patient is having history of constipation. No history of constipation. Irreducible swelling, constipation is a very predominant symptom.
Yes.
Okay.
Okay, go ahead. Examination.
Patient's general examination. Patient was examined under adequate light and exposure with informed consent. Patient is conscious and cooperative and well oriented to time, place, and person. Patient temperature is normal. Pulse is 88 per minute in the right radial artery in the supine position. Blood pressure is 120 by 82 millimeter of mercury in the right brachial artery in the supine position. No evidence of pallor, icterus, cyanosis, clubbing, or lymphadenopathy. On systemic examination, on the respiratory examination, bilateral air entry is present. S1 heart sound is present with no murmur. CNS is conscious, oriented, and alert. Pure abdomen examination is soft, non-tender, and per rectal examination is normal. On the local examination, patient was examined in the standing and in supine position. I will describe the right side first. On inspection on the right side in standing position, approximately 5 by 3 centimeters spherical shape swelling in the right inguinal region. Overlying skin is appear normal. Impulse on coughing is present. No visible peristalsis. Penis is in the normal position. In the supine position, swelling reduces in size. This is a photo of the patient, clinical photos of the patient in the standing position and in the lying down position. Patient is asked to cough. There is bilateral cough impulse present. This is a demonstration of cough impulse which is present on the bilateral inguinal region. On the palpation, in standing position, there is normal temperature over the swelling, no tenderness, 5 by 3 centimeter size swelling in the right inguinal region, spherical shape, smooth surface, soft in consistency, swelling presents above and medial to the pubic tubercle, palpable expansile cough impulse is present. In supine position, swelling decreases in the supine position and completely reducible. On deep inguinal, deep ring occlusion test, swelling appears on the cuffing, while bilaterally testis is normal on palpation. On percussion, resonant not over the swelling. On auscultation, vowel sound appears over the swelling. This is a demonstration of the deep ring occlusion test of the patient. For deep ring occlusion test, after complete reduction of the hernia, thumb is placed over the mid-inguinal point, which is 1.15 centimeter above the mid-inguinal point, and patient is asked to cough. The hernia is protruding medial. On the left side of the examination.
I think we will skip left side. Rajan, it will be
only
concentrate on right side.
Right. Yes, sir.
We consider that yes, left side is there is hernia, and it also appears to be direct according to, right?
Yes.
Smith, okay.
Yes.
Further, because it will be repetition.
Yes.
Further now.
Sir, I want to say that first of all, he has said, you have said.
Let him come to summary. There are so many things we would like also ask. Summary now. Further, anything further? Go next. Percussion. Okay.
The resonant note over the swelling present. In auscultation, bowel sound present.
Okay. Summary now.
On the summary, a 70-year-old male patient, chronic BD smoker, working as a farmer, presented with the chief complaints of bilateral inguinal region swelling since last 6 months, gradually increase in the size and increase on coughing and straining, and decrease on the lying down, associated with the right side of the pain since last 1 month. On examination, on right side, a single soft spherical shaped inguinal swelling of 5/3 cm present with expansile cough impulse, completely reducible, and swelling appear after the deep ring occlusion test. On left side, a single soft spherical shaped inguinal swelling of 3/2 cm present with expansile cough impulse, completely reducible, and swelling appear after the deep ring occlusion test. So my provisional diagnosis in this case is uncomplicated bilateral direct inguinal hernia with intestine as its content.
Okay, Vinit, you were pointing something. Yes.
Sir, one thing. The first thing is that he has mentioned, Smith, you have mentioned that it's a spherical swelling, and the dimensions you are mentioning is that 5/3 centimeters. So that itself, it is contradictory.
oval.
It should be 4/4 or 5/5 rather than 5/3. 5/3 is more of a piriform, which suggests more of indirect hernia. So that you have to be careful about in the history.
Okay. Rajan bhai, madam.
Let the madam ask. Madam has not asked any question.
Sir,
Go back to the first slide.
Yes, ma'am. Go back to the first slide. Smit.
Examination slide. No. Okay.
Yes,
Sir.
ma'am.
Sir, I would like to ask one more thing, that when the examination was today, did you ask that did you explain the patient about everything what you are going to do, like informed consent? This is also important before examining.
I think he has written there.
He has
Okay,
written
sir.
informed consent.
Okay, sir. Okay, sir. Thank you, sir. Thank you,
In
sir.
general examination, go to general
Okay,
examination.
Yes, sir.
Yeah, patient informed consent.
How what did you tell the patient
Yes,
before?
that is a more better. Yes.
Yes. What did you tell?
Sir, ma'am, we should explain the patient about the examination we are going to over the patient in then his language. I tell him that I will examine your bilateral your swelling in the different position with adequate exposure from this with adequate exposure and.
Okay. Okay, you need to explain each and everything why you are going to do it. And when he is comfortable, you will tell that you need to make him comfortable. You will explain each and every test what you are going to perform on him, so that the patient is comfortable, and that's it. Thank you.
And you should actually explain there might be slight discomfort or pain, which won't cause any problem.
Yes, sir. Yes.
The kind of test you are going to conduct can have a right?
Yes, sir.
Rajan bhai?
Yeah. Go to your slide of right side examination.
Yeah, local examination, Smit.
Yeah, local examination. On the next slide, go to the next slide. Palpation only. Yes. You have mentioned that The swelling is above and medial to the pubic tubercle. Are you sure that it is above and medial to the pubic tubercle?
Sir, it is above and yes, sir. Medial to inguinal ligament.
You have mentioned it is above and medial to the pubic tubercle. That's why I'm asking.
Yes, sir.
What is the normal size of superficial ring?
It is 1.2. It is subnormal is hardly admit the tip of little finger.
Tell me the size.
What is the size? Whose little finger?
Smit, you have to be very specific.
Okay, if it is a little, if it is, I agree, it admits the only little finger. If there is your swelling comes out of the superficial ring or not?
Sir, in this, my swelling is not comes out to the superficial. It is only bulging from the posterior walls.
To appear on whatever examination you have done, I think it is reaching into the root of the scrotum rather than a bottom of the scrotum, but it has started coming out within the scrotum. Left side is within the confined to the inguinal ligament, inguinal region, but on the right side it is coming out of the superficial ring. That's what I believe.
I agree. Because that's why it looks oval.
Yes, sir.
And two things you have to remember, beta. A normal ring is medial to the pubic tubercle. It is 1 to 1.5 centimeter, facing towards downward and medially, right? But cruras are in such a way that when that swelling starts coming out of the superficial ring and stretching takes place, the lower part of the whatever we say lower part, which starts separating more because medially there is no space.
Yes.
So usually once the swelling come out of the inguinal, superficial inguinal, they are usually over the pubic tubercle or medial or lateral, either of the side. Most of the time it is observed that it is lateral to the pubic tubercle because the ring stretch laterally only.
Yes.
So normal ring medial, stretched ring lateral.
Yes.
So don't make that such mistake.
Yes.
And there are papers for that also.
Yes.
When the swelling has come out, it is usually been found to be lateral to the pubic tubercle. There are 2 or 3 papers that are there.
Yes.
So you can quote that and say bluntly, it is above or lateral to the pubic tubercle rather than saying it is medial to the pubic tubercle.
Yes.
That's what I want to point out.
Yes.
Yes, sir.
Madam, you want to ask something?
No, sir. The same thing sir has already asked. Yes, sir. Thank you, sir.
Vinay? Okay.
No, sir.
My another question is how you have done the percussion over the swelling?
Sir, I done percussion over the swelling, sir, in the patient's sir, one sir standing position which when swelling is appearing, sir, on the swelling is bulging.
But at 3 centimeter swelling, it's very difficult to percuss.
Yes.
When you percuss, swelling disappears because you are giving a pressure to that.
How did you do it in
Right.
standing position? I would really like to know. Is it comfortable to you and patient?
No, sir, but the swelling is reducible in lying down. So,
But why is it necessary to do percussion?
Sir, to give us it will give us sir idea about the sir content of the sir.
How will it help?
So my advice is avoid percussion on any inguinal hernia which is reducible.
Yes, sir.
Another
There's
point
no
is
need
that,
for that.
Another point is a direct hernia of small size, percussion you can't do. You will not get anything. The point here is that in a large indirect hernia, irreducible hernia, partially irreducible hernia, it will be useful to know whether it is a omentum or bowel. But in a hernia which is completely reducible, it has no value. Similarly, why you have separated in standing and supine? How do you do deep ring occlusion test? In standing or in supine?
we can do.
Can, don't say word can. Can is like your authority. I am asking you, book.
It is done in the.
We can do anything we want, but we are not here to do anything we want to know actually what is described.
It can be. It is.
Can, don't use word can. Can is a very wrong word. I will do.
I will do it in the standing position of the patient after complete reduction of the.
You are written it in supine position.
Yes.
So why did you separate standing and supine two differently? It is always combined approach. There is nothing like standing examination and supine examination. From where did you take this part? Separating supine and standing? There is nothing like that. You have to do combine. How do you do deep ring occlusion test?
In this, I do, sir, in this patient, sir, I do in the supine position.
No, I am asking you general. How do you do deep ring occlusion test as a whole? Forget about your patient now.
After complete reduction of the hernia,
So how do you completely reduce the hernia? That is the first thing. See, Sahib, એટલા માટે તને પૂછી રહ્યા છે. Why it is a combined approach?
Sir, hernia is completely reduced by the process of the taxis. We can guide the hernial content back to our cavity. Then we locate the deep inguinal ring, which is 1.25 centimeter above the mid inguinal point, and we put the thumb over the deep inguinal ring. After that, we ask the patient to cuff, and we assess that swelling is appears or not on the deep ring occlusion.
So cuffing is done in lying down or standing?
In a standing position.
So it is combined. Why you ask the patient to do supine? Because many hernia does not disappear in standing position, and you cannot reduce any hernia in standing position, right?
Yes.
And
another thing I want to add, Smith, that you have to first say that for reducing, first I will ask the patient to reduce. If he can reduce himself, that is the best thing. And if patient is not able to reduce, then I will do the this taxes.
So first is lie down, it reduces, very good. If it does not, you ask the patient to reduce, and then it still you are having issues, then you can, but taxes should not be done unless it is required. It's a painful procedure, and you can even harm the patient.
Right. So the another point is that you said palpable expansile cuff impulse is present. How did you know that it is the expansile cuff impulse? Describe it. This is for all our students, not for you only.
Sir, for if there is a we put for the palpable cuff expansile cuff impulse, I put my finger after reduction of the swelling, I put the finger over the site of the swelling, and ask the patient to cuff. There is the finger is taken away.
See, beta, this is a trap, right? It is when there is a swelling is reducible and you are doing a deep ring occlusion test, it is usually a visible expansile impulse rather than a palpable. Because for palpation, you have to use another hand. Because one hand is holding the deep ring. How can you go for palpation of the other content? So that is a trap. And that is the reason you are being trapped here.
Another point is that you can still do it, but you have to use two fingers. Expansile finger is elevated and separated. Or you can use one finger, one hand with forefinger and thumb when the hernia enters the scrotum. You put it at the root of the scrotum and ask the patient, they are separate. The word here is separated. You cannot do it with one finger. That's the point. Expansile means elevation and separation of finger, which is the other type of impulse.
One is one is expansile, one other is transmissible impulse.
Transmissible. It is not a disease.
Transmitted.
So when will you find transmitted impulse?
Transmitted, sir, when there is a below the swelling, there is a another vascular, it is seen in the vascular swellings, like when there is aneurysm or at the
You know that aneurysm will have an expansile impulse.
below
Aneurysm has an expansile impulse.
Smit, don't go. See, the problem is you are going absolutely by book.
We are talking of inguinal region. In inguinal region, which swelling will have a transmitted impulse. Hernia will always have an expansile impulse. You know any other swelling in inguinal region which will have an impulse on cuffing present? This is a very elementary question of undergraduate.
varicocele.
Varicocele. So, how will you differentiate varicocele from the inguinal hernia?
Sir, in the varicocele, there is a in the inguinal hernia, it is a there is a communication to the peritonal.
No, I am not asking theory. We stick to the impulse on cuffing. What is difference? So, inguinal hernia, fingers will be elevated and separated. In varicocele, it will be only transmission of intra-abdominal pressure. That is, there are other difference. We'll not go in that detail, bag of worms and that. How do they reduce? Another point is that you said reducibility. How do inguinal hernia reduce and how the varicocele reduces?
Sir, inguinal hernia reduces, if it is a smaller in size, it can be completely reducible on lying down.
By smaller, larger, why you are worried? Stick to the answer. How the hernia reduces, how the varicocele reduces. Small, large doesn't matter. You know that is a reduction from above, reduction below. Go and read everybody of them because we usually ignore varicocele. That is the problem. And some examiner like me may ask you so many questions of varicocele. It is a differential diagram. Any other swelling in this region will have a transmitted impulse? There are actually three you should remember. One is varicocele, second is a lympharix, and third is a saphenavarics. Right? Any other swelling which can have an impulse in this region? There is actually one more, that is psoas abscess. Keep that thing in mind. It can have an impulse on cupping. Though presentation and everything is different, this is just to complete the list. Right? Have you done Zeeman's test? Sorry, Rajan, you were asking something.
Yeah.
Please.
So in continuity to that, the only thing which you have to remember is this expansile impulses of saphenavarics or whatever the sir has described is below the inguinal ligament rather than it is above the inguinal ligament. So this is a separating point which you keep in mind also.
Yes.
Another thing I want to ask you, what is the difference between reducibility and compressibility?
In a different in compressibility, after after reduction of the swelling appears on its own without act of any straining. Where in the reducible swelling, the swelling reappears after the act of straining.
So that means that in reducible, whenever there is an intra-abdominal, if it's a reducible, if there is intra-abdominal pressure, then only it will appear.
Yes.
And in compression, it will, in compressibility, it automatically appears without any intra-abdominal pressure.
Yes.
So in compressible swelling, there is having a inert pressure is there. So you just reduce the pressure by compression, but as soon as the pressure goes, the inert pressure will make the swelling appear. Right?
Yes.
So that is the only thing which you have to keep in mind.
Another question is that what are the fallacies of this deep ring occlusion test? Fallacies, I think you know that if you are doing it, still the opposite thing, like the if you are pressing it, if it's an indirect hernia, still you find that there is a appearance of swelling, or if it's a
Why false positive and false negative?
false negative.
When there is a deep ring is a petulous larger deep ring, or there is a if there is a double pantaloon hernia that
So there you will have false positive or false negative.
Falsely, sir, positive deep ring occlusion test, sir.
And what the other way around? Even if it's a
When we compress, sir, we compress, sir, more than the area of the deep ring, then it is gives a false negative, improper technique for the deep ring occlusion.
so the size of the thumb and the size of the
thumb,
finger,
size of the
right?
And what is proper technique?
Sir, put the thumb over the deep inguinal ring, which is 1.25 centimeter above the mid inguinal, after complete reduction of the nail, 1.25 centimeter above the mid inguinal point. And
So what is mid inguinal point?
mid inguinal point is the midway between the anterior superior iliac spine and pubic symphysis.
What is the shape of deep ring?
It is a U-shaped deep inguinal ring shape is used.
So from where does you should apply thumb?
Sir, we should apply the thumb if we want to examine the right side. We have to apply the thumb of the left side with resting our fingers.
Go to your deep ring occlusion test.
The video.
For deep ring occlusion test, after complete reduction of the hernia, thumb is placed over the mid inguinal point, which is 1.25 centimeter above the mid inguinal point.
So the what wrong you did, you showed pubic tubercle and not the pubic symphysis. That's I noticed at that time.
The hernia is.
Did you understand?
Yes.
So you should, that is pubic tubercle you are showing. Yes. Pubic symphysis is more medial.
Medial.
Medial. Do you understand? And thumb position is right. You should apply thumb from lateral to medial like this. Do you understand? So what you are actually showing is midpoint of inguinal ligament. This is a very common problem with most of the students. They confuse them. It is a pubic symphysis and anterior superior midpoint of inguinal ligament. And always find that way. Some have developed tendency, they try to palpate femoral artery and say this is the site of ring. That is additional. You should always depend. And thumb should be applied lateral. Because of the U shape of the deep ring, which faces upward, thumb exactly fits the deep ring and you can do deep ring occlusion test. You should start in supine position and end in standing position, which you have not done again. Okay.
Okay, let us proceed to your diagnosis and management part.
Rajan bhai, 1 or 2 points for our students I would like to confirm. One, he has rightly not mentioned of invagination test and Siemens test.
Yeah, this is what my message is also.
Yes,
invagination test and Siemens test are not mandatory or should not be done.
Exactly. So that is the right thing. But one test you have not done. You are confused. Systemic examination, inguinal examination is part of per abdomen examination. You should understand this point. So you have already mentioned per abdomen, and that's why you have missed 1 or 2 important points. One is tone of muscle. Have you seen the tone of muscle or no?
Sir, yeah, I seen sir tone of muscle on sir layers.
Where have you said it?
Sir, I didn't mention my paper.
Yeah, it is one of the most important point in an inguinal hernia. What is Malgain's bulging?
Malgain's bulging is the abnormal bulging of the abdominal wall due to its weakness,
which part will have a bulging?
It is mainly seen over the lateral abdominal, lateral side of abdomen.
Where? No, exactly where it is. Can you show it in the picture or that photograph?
Spigelian. Spigelian area.
No, not Spigelian.
Malgain's is right. Your word is right, but where is not correct. Malgain's
the point is that it is actually between anterior superior iliac spine and deep ring, lateral, lower lateral.
Yes, sir.
It is not actually inguinal region. That shows the weakness, and it should always be looked in tangential region, right? So, what are the methods to test muscle tone?
Sir, I asked the patient to raising his head with a shoulder raised, and another is a straight leg raising test. Ask the patient to simultaneously raise the both legs from the bed, sir.
So how does it work?
On sir, straight leg raising test, there is a from the hip is flexed. So there is any sir any legs abdomen is present. It will bulging out.
No.
There
How
is
does the straight
increase in
leg
the
raising test
intra-abdominal,
work?
which cause increase in the intra-abdominal pressure. And
Why? Why it causes increase in abdominal pressure? What happens? You know, in straight leg raising test, you flex the hip, but keep the knee straight. If you also flex the knee, muscle become, that means abdomen will become lax. That is the way to examine abdomen. What happens in straight leg raising or shoulder raising that causes increase intra-abdominal pressure? It is because of the fixation of the pelvis. The flat muscle or seat muscles and rectors are important for fixation of pelvis. So when you do straight leg raising test, for the muscles arising from pelvis to work, the pelvis has to be of the leg, pelvis has to be fixed, and that causes the contraction, strongest contraction of abdominal flat muscles, and causes the increased abdomen. You can judge the tone of abdomen. Why the tone is important?
sir, for we can for the tone of the muscles in the direct inguinal hernia, there is a legs abdominal wall muscle is a.
Sir is asking what is the importance of tone?
Good tone can prevent the lesion.
There is a something like I don't know word. You know that?
I don't know, sir.
That is it. It is not necessary that you are supposed to know each and everything. Right. So the point is that in today's scenario, we exclusively put a mesh in all patients. But by looking at that, we can judge and if the larger mesh is required or something else is required or not. Particularly in the era of a laparoscopy, this will be useful. That we will discuss when the management. So it has a bearing on the size of mesh and the management and overall general condition of patient. Particularly when the patient has a direct hernia, the tone of muscle should always be judged. Which is the best method to judge tone of muscle? Abdominal muscle, I mean to say. That is a Valsalva maneuver. That gives you the best idea. Okay. I think we should proceed now. There are so many things we can discuss. Similarly, one question I wanted to, how did you hear the vowel sound? Like percussion, we already. So if there is a doubt, just ignore them. Don't speak about that. And per abdomen examination comes a finger, or it is a part of that. It is not that. Systemic examination is fine, but this is a part of per abdomen examination. Don't forget this one. Okay. Vineet, anything else, Rajan bhai?
Smith, suppose this patient is having a irreducible hernia. Whether you will able to differentiate it is a direct hernia or indirect hernia, partially irreducible hernia.
Yes, sir, partially reducible hernia.
Can you say that is a direct hernia or indirect hernia?
Sir, we can, sir, I can, sir, assuming that patient history and age,
Your answer should be blunt and straightforward.
Again a trap.
Yeah. Once there is a partially reducible or reducible hernia, you are not able to perform the deep ring occlusion. The prerequisite for the deep ring occlusion is swelling should be completely reducible. Right? So swelling is partially reducible or irreducible. That is, you cannot differentiate it whether it is a direct hernia or indirect hernia from deep ring by saying that it is a deep ring occlusion test. Right? So this is a trap. These are the traps I have seen in the exam. And you tried so many students try to justify that. Yes, sir, I can do that, I can do that. But your answer should be straightforward.
Dr. Priyanka, anything on your side?
So one question from my side, that as sir was saying that partially reducible and reducible, completely reducible. Can Samit, please, can you tell me about what is the difference between like incarcerated hernia and
incarcerated hernia is the where
strangulated? Yeah, please.
In incarcerated hernia, there is a content of the hernia is filled with a content like feces material, and in the strangulated hernia, there is a cut off of the blood supply to the herniated bowel.
No, in incarcerated hernia, the content of the hernia is adhered with its wall. It's not like that feces will be there. Incarcerated can be can in the later stage can call obstruction, but it will be adhered. Like content will be the content of the hernial sac. It will be adhered with the wall. It's not like that feces will be there. Then only it will be called like incarcerated hernia.
Both the things can be correct, but basically it's incarcerated is an irreducible hernia without any complications.
Yes, sir.
Right.
And later it can cause like obstruction and on the later stage. Okay. Thank you, sir.
Right. Suppose in continuation of that question, what will be the difference in your examination if it is an irreducible hernia?
In irreducible hernia, the taxi should not be tried if the swelling is showing feature of obstruction or strangulation.
I am asking you irreducible. Remember, you will never get a case of obstructed or strangulated hernia in your exam. That is for theory part. You will never get that case. So we stick to irreducible hernia.
In the irreducible hernia, there may be the cough impulse may be not
very good. Very good.
Case.
One is that cough impulse may be distorted. You may not be able to appreciate complete cough impulse. But yes, what else?
Sir, then sir, we can't assess the deep ring occlusion test in irreducible.
Fine. Very good. What else? Consistency you can judge. Remember.
Yes.
In an irreducible hernia, it is important to judge consistency. So what are the different type of consistency you will? If
it is deep, we can assess the contents from the consistency, like a soft in the consistency, which is which may maybe suggestive of the intestine. If there is a doughy feeling,
soft or some other word is used.
Elastic, soft and elastic.
Elastic. What else?
Then if the feeling is doughy type feeling, which is
doughy or granular, better word.
Doughy and granular type feeling, which is suggests the momentum as a content.
Momentum. So that is the one more thing in an irreducible hernia. In an easily reducible hernia, it is very difficult to judge consistency, judge the I think percussion and to do auscultation. But in an irreducible hernia, again, percussion and auscultation becomes important. Right? So what is the commonest irreducible hernia occurs on left side?
It is most common, mostly those left inguinal hernia as inguinal hernia most common. They are the most common irreducible hernia.
Left irreducible inguinal hernia, which is a common content without obstruction.
Sigmoid colon sliding type of.
Sliding. So that is the one more thing you will look for and be prepared. So if somebody asks you left side irreducible hernia, it can be a sliding hernia. What is sliding hernia?
Sliding hernia in which the posterior wall of the hernial sac is made of the content of the in the left side it is sigmoid colon, or on the right side it may be cecum. Or
what is posterior wall of sac?
Yeah.
Is there any anterior wall and posterior wall? It is a circular structure. One wall, you should say. One wall is usually lateral wall is formed by a sigmoid colon. Right? So that should be kept in mind. I think it is sufficient.
Just one more thing I would like to add.
Yes.
When you have the side of a sliding hernia, you can get that expansile palpable impulse, right? Because it is a partially reducible hernia. At that junction, you can say that there is a palpable impulse because swelling is there. It is partially going, partially coming. So at that time, you can able to palpate. You may not visibly demonstrate that. So this is expansile impulse, but you can definitely palpate that impulse at that junction.
So in case of irreducible hernia, what is reduction and mass? What do you mean by the word reduction and mass?
when we forcibly pushes the content through the deep inguinal ring, and whole hernia with the taxis, whole hernia is going into the peritoneal cavity.
So the hernia does not get reduced. The whole content, the hernia as such with the content goes in the abdominal cavity, right? Okay.
So what is the disadvantage of that? That's why you should not do taxis.
Sir, if the bowel showing the feature of obstruction or strangulation, we can by doing the taxis, we can do the part of that gangrenous bowel goes into the peritoneal cavity.
Let me ask differently. Smith, what happens when hernia reduce? What does get reduced?
Hernia contents of the hernia we reduce.
And what happens to sac? Very simple question I'm asking.
When you reduce hernia, what happens to the sac, sir?
Sac, sir, sac is all not reduced. If the
I'm not sure. Is there any doubt?
no, sir,
Sac is made of
peritoneal coverings.
peritoneal covering. It is extension of peritoneum.
Yes.
It is the extension of peritoneum, which right. So does sac get reduced?
Sir, sac is not in irreducible hernia. Sac is remain in.
I am talking of any hernia.
સાહેબ કહે છે hernia reduce કરી દીધું. Sac reduce થશે કે ખાલી hernia content?
Only hernia content.
So why I have asked this question, it is very simple. When reduction and mass occurs, it is a sac with content get reduced. When hernia reduces, only content reduce. Our aim is to reduce content, not the sac. But when sac forcibly reduce along with the content, it is reduction and mass. You get my point?
Yes.
So you need lot of taxis to do that, but it has happened, right? So understand this point, that what actually reduces in hernia and what does not reduces hernia. Right? In an irreducible hernia, patient does not have an obstruction. But when you do reduction and mass, intra-abdominally, it will convert into obstruction because it has content gone inside along with the sac. Right?
Yes.
Okay. Please, diagnosis. We can go on discussing, but there is no end to it.
My provisional diagnosis is a patient having has a uncomplicated bilateral direct inguinal hernia with intestine as its content.
Rajan
What
bhai,
will you do now?
Sir, એક જ વસ્તુ. Why should it be a provisional diagnosis? Do you need any investigation to prove your diagnosis?
Sir, in this case, on clinical examination, we can made our diagnosis in this.
So, in this case, especially in a case of hernia, I think you can say that my diagnosis is uncomplicated inguinal hernia, direct or indirect, whatever.
Okay, no problem. Because it is a usual provisional diagnosis writing. So that's why be the reason he was right like that. But Apurva is right. It is a hernia is a clinical diagnosis. It doesn't require any investigation. Right? Still also we are doing what investigations to diagnose the hernia? Tell me.
Rajan bhai, let me ask a very simple, because I'm a very simple person. I would like to ask me, define hernia.
Hernia is a protrusion of a part or a hole of a viscous through the cavity containing it.
Here, one important word you have missed.
Yes, do not.
Only one word which is important.
Covering.
No. This abnormal protrusion.
Abnormal protrusion.
It is not a normal protrusion. Abnormal protrusion of content or part of it through normal or abnormal opening content with cavity it contains. Always remember, hernia is definition is commonly asked. Just for a short question, why do you say it is direct hernia? After so much of discussion, you should be able to convince me that it is direct hernia. because this question will be asked, and then you have to use starting from history. That's why I consent, and we discussed that in history also it is very important to say it completely reduces on lying down, appears without any further ado in standing position, and don't rely only on deep ring occlusion test. You should start with the patient is an old patient,
Yes.
old age patient, like that. So sometimes examiner may ask you, why do you say it is direct hernia? More in undergraduate, but if you are not perform well, this can be your savior, because then they will judge, let us know whether he knows basics or not. So you should understand this point. How do you, will not go in further detail. Intestine, I don't know. Anyway, let us go. Okay. As the Rajan Bhai asked, what investigation you will do, or straightway go for our treatment?
In this case, we have done just investigation for the pre-anesthetic workup. Otherwise, the diagnosis is based on the clinical basis.
At 70 years of age, I think you need a USG at least to rule out BPH.
Patient,
Even if the patient does not have any symptoms, but definitely you need ultrasound for this at least.
Okay. So any specific investigation?
For this case, sir, we USG for prostate and PVRV and chest X-ray.
So is it an USG mandatory for hernia or not? Rajan Bhai, these are very common questions nowadays asked.
There are two things. Yeah, you answer first, then I will let you
Yes.
add
USGs
something.
are not compulsory in the cases of a hernia. It can be given as a adjuvant investigation, or if the diagnosis is in doubt.
See, the important thing is to diagnose the hernia, you will not require a ultrasonography. To find out any associated pathology or physiology which leads to the rise in the intra-abdominal pressure, for that only we required a screening ultrasonography, right? But to diagnose hernia, it is not mandatory. But nowadays, we always ask for that, and our radiologist friend always writes there is 3 millimeter, 5 millimeter, 1 centimeter, 2 centimeter defect, right? I don't know what is the meaning of 0.5 centimeter defect in the right inguinal region. By so many radiologists are writing like that. So for diagnosis purpose, it is not required. To know any other intra-abdominal pathology, it's part of a routine.
Yes, it is. And at the age of 70 years, it is right. At the BPH, there can be a residual urine, any other pathology for that. And in unilateral hernia at the 70 year of age, that question we'll discuss that. In ultrasonography, if they say it is a bilateral hernia, should we operate bilateral or not? That is the one more point.
Second thing is, so many times patient may not give the complete history, but on ultrasonography, you may find there is an enlarged prostate, or there may be a, and then later on you ask the patient about the description of that, find out what is the problem with the prostate or a bladder, you may get history. So that is just for a purpose of completing the investigation, you can go for it.
Same thing for X-ray test. You have said that the patient is a BD smoker. So smoker's cough is very likely, for so many years he is having 40 BD packs per day. So I think that is again important for this patient from maybe emphysematous chest, maybe some something.
In this patient, X-ray test is mandatory because he is having chronic smoker. He may have a bronchiectasis changes. He may not have a cough. That's altogether a different thing. But for a longer period of a smoking may lead to the bronchiectasis changes.
Yes.
And it will help us in a management.
Yes.
Okay, what will you do? Suppose it is now bilateral direct hernia. What will you do?
In this case, sir, I will go for the laparoscopic hernia repair laparoscopic mass hernia repair.
Why not open?
We can in the this is the case of sir bilateral direct inguinal and a small so laparoscopy is better, and in the laparoscopy the chances of the inguinal is lesser than the open hernia surgery.
How much percentage inguinal has reduced the laparoscopy?
In laparoscopy, it is a percentage like less than 2%, and in the open hernia, it is approximately 7 to 8% chances of inguinal hernia.
Anyway, I do not want to fall more of the things into that, but we'll later on discuss. It's not only that part, right? If suppose this patient having later on a CA prostate and he wants to go for a radical prostatectomy, what will be the future?
What will be, sir? Sir, I can't get the question. What?
Now you have you have asked for a laparoscopic hernia and patient diagnosed with a later on CA prostate and he want to go for a radical prostatectomy.
Yeah.
Is it easier?
No, sir, it is. Don't know, sir.
Anyway, this altogether a different thing, but
Your answer was
inguinodania occurs in both the conditions. The
Yes.
only advantage of laparoscopic early postoperative pain is more in the open hernia, which is less in the laparoscopic hernia. But at the 6 months or a 1 year, there are plenty of literature available. Only it hardly makes a difference of 1 or 2% change in the inguinodania. Right? So it's not a gross change.
What is gold standard?
Yeah, what is gold standard?
Gold standard is open hernia technique, open hernia repair.
So why you will not go for a gold standard?
Smith, don't say gold. When it is gold standard, you have to say specific technique.
Open lichen stent tension free hernia repair.
So why you don't want to go for that? So what is the rate of recurrence in open and versus laparoscopy?
In the best possible center.
Obviously. This is what I said initially. These are the questions which are going to be asked in exam. I am not in favor of open. I am not in favor of laparoscopy, but this is a fact defect. So even today for all students, if somebody asks gold standard, open lichen stent repair is a gold standard. But yes, laparoscopy is an option. It's a good option. But you should know one is a pain and second is a recurrence. These are the two standards on which we judge any hernia repair.
And one more is a part under seroma formation, sir.
Seroma formation.
Yeah. So the literature itself, which is published without bias, have said that it is 5 to 15% of seroma formation rate is there.
And Smith, when you are given an option of Rajan Bhai asked you about the what surgery you will offer, don't say laparoscopy. Say TP or TAPV. You have to be very specific. See, when it comes to the techniques, so if you want to do it, or if I want to do it, I would rather go for a bilateral TEP, which is a definite advantage, if at all you are going in that direction.
And as a resident, suppose you've been asked for how will you do it? So my preference or what my advice is, you always straightforwardly say that I will go for an open inguinal hernioplasty. That should be your answer. Later on, examiner asks what if it is laparoscopy or this or that, because laparoscopy of inguinal hernia comes under a skilled surgery or an advanced surgery. You requires a lot of tissue handling with a minimum space.
Yes.
So if you are well acquainted with the laparoscopic appendicectomy, cholecystectomy, and you can able to work yourself within a confined space, so it is considered as one of the advanced surgery in the laparoscopy. So you require the skill to develop that.
Yes.
Vinit bhai?
And that should be your answer for that. As a resident or just beginning of my career, I will prefer to go with the open surgery. If I get the skill to develop hernia later on, yes, we'll definitely try.
Yes.
Then the all the aspect of theoretical questions will come when you will go for a dilate TEP, when will you go for a TAPP, so that you can answer. It's a part of your whatever the hernias has been done in the unit and whatever you have seen. But as far as the residents are concerned, just passing for MS examination, your preference should be open. You can answer it well. Smaller points, finer points of open inguinal herniorrhaphy or a hernioplasty. And your discussion should be more defined to that area.
Yes.
Nowadays, lots of people are promoting that the laparoscopy should be gold standard. But in last only ASICON, I have been given that topic. And I have literature, worldwide literature, I have proved that only 5 to 7% of the hernia, till now it has been by the laparoscope. Means 90 to 92% of the hernia still done worldwide with a large volume of more than 25 lakhs to 30 lakhs hernia per year all over the world. Only 5 to 7% have been done with the laparoscopy. And only 5 to 7% of surgeons who are very trained in laparoscopy, they are doing 80 to 90% of the laparoscopic hernia work. That is what world literature says. That's what I want to comment.
Second point is that they are more vocal, they are supported by companies, and obviously it is very, very attractive to the patient. So yes, but remember, as a resident, as Rajan Bhai said, your first choice should be, and I believe I may be wrong, is a bilateral open. Let the examiner ask you what you will do. Why not?
Sir, I will tell my journey only.
Hmm.
I have started doing laparoscopic hernia since 15 years. But my recurrence for first 50 cases are more than 10 recurrence. That means it is more than 10% recurrence out there. First 50 cases, 20% recurrence. Slowly it has come down. And still my preference is for bilateral direct hernia, which is grade 1 or grade 2, which is not reach up to the scrotum. We do laparoscopically. And TEP, not all hernia. Because I have seen at present also, if it is reaching into the scrotum, these patients are, our own patients are having 5 to 10% seroma formation. It is very difficult to convince the patient later on. Because patients come with the swelling, we are giving him back a swelling in 7%, 7 to 8%. So recurrence we are not giving. So what I have started telling to remaining of the hernia, whether it is an inguinal hernia itself or a seroma, it is a recurrent. To me, it is recurrent.
At least for the exam point of view, you can say first preference is this, and then, but there is always an option of laparoscopy.
Why not TAPP? Why TEP? We'll come to open little later. I want to ask some question in open.
In this case, the swelling is a bilateral, so we can go for ETP. So we can.
Sir is pushing why is asking. Sir is asking why TEP, why not TAPP?
And you said ETP. Why ETP?
ETP because the swelling is bilateral, so we can.
No, why ETP?
TEP will not
Peritoneum is not breached in the TEP repair.
What did he say?
No. Yes, I have TAPP नहीं बात अभी. Sir is asking why ETEP and not TEPP.
You use word ETEP. Why ETEP? Or it was by mistake?
No, bilateral we can.
अब विनीत भाई ETEP करा जाए.
I want to ask what is the difference between TEP and ETP?
That's why what I am asking. વિનીતભાઈ કરે પણ જવાબ આપતો તારે આપવો પડશે વિનીતભાઈ નહીં જવાબ આપતો
અમે બી કરીએ છીએ યાર અમે બી અઠવાડિયામાં 2 લેપ્રોસ્કોપિક હર્નિયા અમારે ત્યાં થાય જ છે
હું નથી કરતો
દરેક ઓટીમાં એક હોય છે but we have a very stringent selective criteria. Our patients should not develop the seroma.
What is the difference between ETP and TEP?
In the ETP, we can simultaneously access the both
that is even in TEP. That is even in TEP. What is the difference between
covering of?
How many ETP you have assisted, Smit?
3 to 4.
Do you understand or not? I have doubt whether you understand what is E. E means what? What is E?
Extended.
Extended.
Why it is called extended?
Because
I'll give you a hint. Change in the port placement.
yes, sir. We made the ETP port is made put 4 centimeter lateral and above the umbilicus. So sir, there is a plane is larger in the extended TEP, where in the TEP there is only lower to the umbilical port placement is lower to the umbilicus.
Any other difference? Only port placement is a difference. Vinith bhai?
The difference is that extended TEP, or it can, some people call it extended TEP, some people call it enhanced view TEP. That means we are having an enhanced view because we are placing the camera just 4 centimeter above and lateral to the umbilicus. The ergonomically also ETP, why it is better? Because we are looking at the hernia from the front view, whereas in TEP the camera is while dissecting, our two ports are on the midline. So ergonomically also TEP it becomes slightly difficult, whereas in ETP all the ports are placed in front of the in the end, just lateral to the umbilicus. So ergonomically it is better, and because it is an extended, we dissect a large space. So what happens is that the mesh placement on both sides, we can place a bigger mesh, and we can actually it is more easier to create a space as well as to place the mesh, whereas in TEP that sometimes it becomes slightly difficult to create a big space.
Is there any difference in fixation?
No, sir. Fixation, the same thing. That is in the Cooper's ligament. There is no difference. Yes, but we can because we have got an extended space, so we can even suture, which is much easier comparatively in ETP rather than in T.
Yes, that's what I say. It is a more space to work.
Yes, sir.
The curling of the mesh is less.
So we need where your port space placement, particularly your camera port is 4 centimeter above the umbilicus. I agree, but where is the other port? At
The
what
second
side to put?
the second port is at the arcuate on the, like, if we start from the left side. So the
Yeah,
second port will be just at the arcuate line
just
on
at
the
the
left
arcuate
side.
line. Okay.
So, and then the third port will be just like we cut the this linea alba, and we just place it about 1 centimeter below the umbilicus, the second port, and then we then dissect the right side. After dissecting the right side, we can place the
Another port on the left side.
on the right side. Yes, sir. So we get actually we are placing 3 ports, and by placing the 3 ports, easily the dissection and everything is much easier, and we are doing the dissection from the front rather than the sideways in TEP.
Okay.
Okay.
What about
But-
why TAPP?
But what we are I am not doing a E-tap. We are doing it with the medial all 3 ports. And only problem or only area of concern is while when we are putting the mass in the midline, we have to little bit keep the mass or ports in such a way that so mass should be placed medially little bit covered. Otherwise, there is no problem in spreading them. Only area where the lateral peritoneal fold at the linea sublunarius, peritoneal fold is tough and attached. If you cut that part, you can have enough space in the TEP also.
Yeah, definitely TP also, sir. But and because the port placement is slightly near the umbilicus, the problem when this problem which you are saying that ports come in the middle of the mesh,
Yeah,
that doesn't occur, and the mesh easily spreads in ETEP.
agree.
So I wanted to ask Smith that which hernia in laparoscopy should be done by TAPP rather than we try to attempt TEP or ETP? Which hernias, which inguinal hernias should be more attempted for
When the hernia is inguinoscrotal and with a large hernia, TAPP is better for.
Yeah, so that because the we can under vision we can reduce the contents and then we can try to dissect the sac.
Right. Yes, sir.
If it is a large TAPP, how will you reduce the pseudosac, or how will you prevent the seroma formation in a pseudosac?
Don't know, sir. Okay.
He doesn't know. Yeah, he doesn't know. Want to say, I don't know. Smith?
He has no experience on TAPP, sir.
Huh? TEP or TAPP? If it is larger hernia, how he is preventing the seroma? That is the biggest question till now.
Don't know.
Okay, go ahead.
Now, would you like to give
How
some?
will you prevent how will you prevent the inguinodania in open hernia surgery, or minimize?
We can after opening of in open hernia surgery, after opening the external oblique aponeurosis, we should try to safeguard the ilioinguinal nerve while the separation from the spermatic cord. And for the iliohypogastric nerve, while fixation of the mesh medially, we should try to avoid fixation or entrapment of the nerve in the mesh.
Yes, you are absolutely right. These are the two areas. If you can be little bit more careful, whatever the literature or comparison of inguinodania mentioned between the laparoscopic and open hernia can be compared in later on. But early postoperative pain, definitely open hernia has a little bit more pain. But that also a mild to moderate. If you go with the visual analog scale, it are usually we have seen it is 3 to 4 or 2 to 3 rather than a gross pain. So whether it is, you must have to, one has to assess that part also. આ કેવું છે કે 96% પેશન્ટ એ ના થતું હોય, 96%, for example I am giving, but if it is 2% more, 94% is having only 2% difference, how will you promote that thing? 50% more, 50% less. This kind of things are there in inguinodania also.
Okay, considering inguinodania, what are the other reasons? One, you have said preserve the ilioinguinal nerve. Second is to take a periosteum or not. One more thing which is being promoted, which I usually follow, is using an absorbable suture material.
Yeah.
One
Since
more
last
point.
20 years, we have never used the Prolene.
Same here.
I also never use Prolene. Go with the Vicryl, single Vicryl, complete the hernia surgery.
Or PDS, if you are very comfortable with monofilament, but I never use PDS. One more point is type of mesh. I would really like to discuss that part. Which mesh, if you are doing an open hernia, you will use?
I will prefer the macroporous mesh, which is a lightweight and.
What do you mean by macroporous?
Macroporous means pore size is more than 1 mm.
Is it in mm or micron?
Micron, sorry.
So what are the different sizes of weight mesh are available?
Yes, sir. Different.
Weight mesh, lightweight you said.
Vajan per difference.
There is a heavy weight mesh, then which is more than 80 gram per meter square. Then medium weight, which is 50 to 80 gram per meter square. Then lightweight, which is 35 to 50 gram per meter square. And ultra lightweight, which is less than 35 gram per meter square.
Very good. So which mesh you will prefer?
Sir, I will prefer lightweight mesh for the.
Yes, definitely. What is the advantage?
For the lightweight mesh, it is better for the contour of the abdomen, so it is
No, wrong. Lightweight is not better for contour. Huh. What is advantage of lightweight? And to decrease the chance of inguinal hernia, light or moderately weighted mesh are used, macroporous mesh are used. I agree with you, but why?
Sir, better incorporation and
What better? Yes,
incorporation.
incorporation. Yes, macropore causes the incorporation of body tissue easily and mesh merges. Chances of rejection and seroma formation is less, and contraction is also less because of that. So chances of pain is also less in macroporous mesh. Then what is disadvantage?
It is more patient centric. See, you have to, depending on the patient's contour, your type of mesh should be.
What is disadvantage?
It can, sir, it can displaced due to.
First is the handability for a surgeon's point of view. It is not easy to handle, one. Second, because of the lightweight and macroporous, curling is more common. So in a laparoscopy, it is become little more difficult to adjust. Even in open, if you are not careful, it will curl or turn and may cause the problem. And remember, placing the proper mesh is equally important to prevent seroma and rejection. Both are important. So macroporous, you should be more careful while incorporating it, right? So that is another. Yes.
How will you make the mesh macroporous? What is the composite mesh?
A composite mesh means there is an additional of biological material in the synthetic plus biological material combination of that. Sir.
No biological material, right? That is altogether different discussion. No.
What is Vipro? What is Ultra Pro?
Vipro is a combination of the Vicryl plus a polypropylene mesh, and
Ultra Pro is monofilament.
Yes.
Monofilament, right? So what sir wants to say, that part gets absorbed. Prolene
yes.
does not get absorbed, and the pore size little increases, right? So that is a composite mesh. Another type of mesh is a pure prolene lightweight mesh, which is pre-made macroporous mesh. It is literally moderately weight and easy to handle. So understand this point. But the advantage of
what is the, sir, can I ask him one question?
Yes, please.
What do you mean by 50 gram of weight, 60 gram of weight, 80 gram of weight, 30 gram of weight? What weight it is? Suppose I have a mesh with the prolene with Vicryl or a prolene with a monocryl. So how will you consider the weight?
So it is on meter square, 1 meter of the mesh weight this gram.
1 square.
1 by 1 meter square, yes.
1 square meter.
Yes.
But it is only the prolene component of the mesh is considered as a weight, not the absorbable part. That's what my message is.
Yes.
So it is always the prolene content which is considered as a weight. And to remember it very simple, remember is around 25, 50 and 100, 75. So this is more, companies are gimmicks. 65 વાળો કહેશે કે અલ્ટ્રા લાઇટ છે, 70 વાળો કહેશે કે પેલાની આ છે. So simply what I have understood is around 75 it is heavy mesh, around 50 it is lightweight mesh, around 25 it is ultra light weight mesh.
One more advantage of composite, ultra pro and those kind of mesh is that they are easy to handle. They are more stiff than pure prolene lightweight mesh. That is the advantage you should keep in mind. Other point when we were discussing inguinal hernia is, apart from mesh, is a sutures. When you take a sutures, what is air knot?
Air knot, I don't know, sir, about air.
So it is a knot which is not too tightened. When you are fixing the mesh, if you tight too, it will also cause the pain. And we usually ignore iliohypogastric nerve, which lies over the conjoint tendon. So either you should see it and avoid it, or by chance it comes, you take a very light sutures which has some air in between. So it will not cause much of a pain. So these are the causes in open which prevents the pain. Similarly, one more point is that not too tightening the deep ring part. Keep it little lighter in those cases. Otherwise, if it is constricted, can also cause the pain. What is the size of mesh you will use in open, and what is the size of mesh you will use in TEP, TAP?
Open hernia, we generally use the 11 by 6 or 7.5 by 15 centimeters.
No, what you will use? I am asking you. Again, that is the difference. You always come in a mode of exam, not in exam, but theory lecture.
6 by
Thank you.
11.
Why this size mesh are there? 15.7, 15 by 7.5 and 11 by 6.
Well,
In a
for
TEP, Vinit sir, I think you are using 15 by 12.
Yes, yes, sir.
Everybody is
15 by
using 15 by 12 only.
That
With
is
a
fine.
whole side trimming.
That is right, because you need a larger mesh, larger area. Here you need a smaller mesh, smaller area, right? So in a laparoscopy, in which plane it is put? Mesh is put in which plane?
the pre-peritoneal plane.
Pre-peritoneal. So it is a kind of what you call is sublay mesh.
Sublay plane.
So in open, which plane you will put?
In open lichen stent, it is also a sublay.
No, it is not sublay.
Inlay.
It is an inlay.
Inlay plane.
What is inlay? Because we cover external oblique. It is replacing mesh actually.
Yes.
You understand? The sublay, it is replacement from inside. Here he is breaching the cover. Understand this point. What part is covered? Which gap is covered? Canal. Posterior wall is covered. So why this type of mesh? Why these two sizes are there?
Oblique, because we have to, according to length of the inguinal canal and obliquity, there is a more.
What is the length of inguinal canal? What is length of
4
inguinal?
centimeter inguinal canal length is 4 centimeter.
4 to 6 centimeter depends upon the patient. So you need how much long mesh on either side?
The mesh should be covering medial 1.5 to 2 centimeter medial to pubic tubercle.
Very good. 2 centimeter and 3 to 4 centimeter beyond inguinal or a deep ring. So what should be the size of mesh? Now tell me. Minimum 12 to 13 centimeter length should be there. So 6 by 11 is sufficient only in a few patients. I still feel it is not the mesh to be used in inguinal hernia in an adult patient. It is a too small a mesh to be put. 6 by 11, if you fix it, it will barely reach beyond the deep ring. Though people argue that it does not appear lateral to that, but you need because the shrinkage will be there if you have put a standard mesh by 30% minimum. So it will become very small. So I still recommend, do not use 6 by 11 mesh in an inguinal hernia. In exam also, don't say 6 by 11. Always 15 by 7.5 centimeter. You may cut one out because the requirement may be 12 to 30.
It is 12, minimum 12 centimeter mesh should be required.
Should be required. So 6 by 11 is a gimmick again by companies. And it does not come cheaper. Why we should use it? It is useless. Do not use 6 by 11. Most of the rare incidents, fine. That's right. Because I have learned from my mistake. I had an era when we used to make 7.5 15 into 2 mesh and used to use in one when the meshes were costly and not easily available. But now it is standardization. So 6 by 11. Yes.
So what sir has told is the reduction in the size of a mesh later on, or what we call is a shrinkage. That also depends how you have to select the mesh. As the mesh is microporous, it is likely to shrink more because they are going to form a scar plate which contracts more, and that is the one of the more favor of macroporous mesh where the tissue incorporates, right? And shrinkage is very minimal in that. All the meshes 5 to 10% or up to 20% shrinkage is there. But if you are putting a what I say heavy mesh, shrinkage are much higher. Inguinal hernia is much higher because the nerves which you have prevented while when you are operating, but later on it's try to within that clump only later on it contracts and it leads to the pain later on. So later inguinodania are usually because of shrinkage or tough fibrosis around the nerve is the one of the
Literature
reasons.
says up to 40% of the mass shrinkage occurs with heavy size.
Yeah, 40%.
Yes.
Okay.
Smith, one thing I wanted to know, what is the anatomical basis on which people go for laparoscopic procedure? Anatomical basis for laparoscopic procedure.
This I can't get.
Why do people propagate that laparoscopic procedure is better? Of course, pain બધું પછી આવ્યું. What was the basic idea of
It can
doing
cover all the possible openings of the hernial sides.
What is that known as? Anatomical name.
Brochur's myopectineal orifice.
Basic idea was to cover all the fractures, that is the femoral, direct, inguinal, and even if you go posterior, even obturator, but we don't go that deep because of the vessel.
Yes. Yes.
See, 2 or 3 things I would like to point it out. In my 35, now I am 30 years of the career, I have seen only 2 obturator hernias. And once in a year, we are facing a femoral hernia. Pankaj sir is also agree with me. So
I have yet to see a patient of having a femoral hernia in whom I have operated inguinal. See, all rubbish.
I have operated and my publication is there. But what my question is, hypothesis of covering the all hernial orifice to prevent the herniation, that is having no basis.
Yes.
To promote the laparoscopy. That's what I say. And sir, remember my words, after 15 years, people will come back again to the open inguinal hernia surgery only. As the robotics and prosthetic surgeries era will start more and more, and people start challenging the problems of preperitoneal mass, they are start recommending, no, don't waste this space. That era will come.
Okay, so let us come to the basics here. Which surgery you will do in this open? What is the name of surgery? Forget about Liechtenstein. What is the name of surgery you will do? Very simple, basic things. Which surgery you will do? What is that known as? Basic. I am asking very basic question.
Hernioplasty.
Achha, will you do herniatomy or not?
In this patient, herniatomy is not done, as it is a direct component. The sac.
Why you will not do herniatomy?
It is a completely reducible and a direct inguinal.
Even many indirect hernia are also completely reducible. Your answer should be proper. I know we will not do it. I also agree. But why? I think आज तो मैं वो प्रश्न पूछी काढ़ा अपूर्व. हाँ.
Thank you, sir.
अरे नहीं, thank you so यार बहु. मारो favorite topic है ना, problem is.
Right, sir.
Yes.
Why I don't know, sir.
अरे why I don't know चलू चाले ले आ तो वो important वस्तु है यार.
Sir, indirect hernia, if there is a transfixation of the sac is necessary at the deep ring. So
why? That is herniatomy, but why it is necessary and not in a direct hernia? Very simple answer. I am asking you very simple questions. Large neck.
Yes.
Do you understand? In an indirect, whatever may be, the neck is always narrow. So that has to be right. Yes. One more point. Indirect hernia is the sac is along with the cord structure. So you anyway have to dissect it from the cord, and if you do not remove it, it will remain redundant. You cannot bury the indirect sac. So you need to remove. That's you perform herniatomy. Direct hernia is separate. It has its own fascia transversalis cover. So you can avoid entering sac. You do the plication of fascia transversalis over the sac. Sac you do not touch. Yes. So hernioplasty without herniatomy in a direct hernia. Herniotomy and hernioplasty in case of indirect hernia. It's always like that.
Yes.
Right? Okay.
Smit,
So what
Okay, sir,
is
we
the
conclude. I am
Sir,
leaving, sir. મારે
Please.
થોડું કામ છે.
Sure. Thank you. Thank you very much for joining. Please.
sir,
Okay, sir.
Yes.
Yes, ma'am.
sir, can I, sir, Samit, please, can you tell me what is, like we were discussing about TEP and TAP, what is angle of doom, triangle of doom and corona mortis?
Very good.
Triangle
Yes.
of pain.
Great.
In the triangle of doom, in the laparoscopy, the border medially it is the vas deferens, laterally it is the gonadal vessels, and inferiorly it is the peritoneal reflections, and which contains the external iliac vessels. And there is a chance of extensive hemorrhage if the injury or to the vessel occur in that area. Then in a triangle of pain, the medial border is by the gonadal vessels, superior boundary is by iliopubic tract, and laterally it is a peritoneal reflection, which contains the nerves of the femoral nerve, lateral cutaneous nerve of thigh, and genital branch of genitofemoral nerve. And any injury to this region will cause the chronic pain into the patient. And corona mortis is the presence of abnormal obturator artery, which from the inferior epigastric artery, which can, if present, lead to the torrential hemorrhage while performing the surgery.
Good. And one more thing. Can you please tell me, while placing the mesh, if the if the patient is having hernia on any one side, like right inguinal hernia, and you are doing TEP, what will be your mesh placement? Only you have already told. Just tell me ki kahan se kahan tak, from where to where it will be placed. What you have to take care. Only right side.
So the anatomical landmarks.
Yeah.
How you put the
Yes, sir.
mesh.
Yes, sir.
We have to cover the region of medially up to the pubic symphysis and symphysis, and below and above the all hernial orifice is covered.
Smith, you will go only up to symphysis? What do we do? Do we cover only up to symphysis, or we go a little this way or that way?
We go medially, sir, up to
Little bit late.
Right?
Laterally up to the near to the ASIS.
Laterally is ASIS, but medially?
Don't know.
Please, ma'am.
From ASIS and medially you were telling.
Don't pubic pectineal ligament. Don't know, sir. Don't know.
Little bit you will cross that.
You always cross the midline, right?
Yeah, you will cross that.
Fixation is a pectineal ligament, but you will always cross the midline. That is true for both open as well as laparoscopy.
Yes, sir. And one last question, Samit, that if this patient is coming, you did that you approach this patient through through TEP, and after 2 years he is coming with a recurrence on any one side, then what approach will you take?
I will go for the open Lichtenstein repair in the recurrent hernia.
Okay. Thank you, sir. Thank you.
Okay, Smith, I want to ask you about open hernia. That while dissecting the sac, what should be the landmark that yes, in indirect sac, this is the place till where we have to dissect in indirect hernia?
Up to the deep inguinal ring, up where the preperitoneal fat we can see.
So one is preperitoneal fat. Second, any other landmark?
Inferior epigastric pulsation of inferior epigastric artery.
Right.
And third landmark? Narrowing of the sac. The sac which was large once become narrow. It is a classical point of neck, which you can appreciate if you have dissected, and then again it becoming enlarged. That is the actual site. Why is it important to find out the neck? પૂરો રખિયન ચાલુ કે બંધ કરવું છે?
ના સાહેબ હું અહીંયા જ છું.
We can go on discussing, but we'll stop after. I would like to ask few questions, which I know.
So what is high ligation? I have no.
Neck is the most. Neck is one of the most constituted part of the hernial sac. And we have to reduce the content beyond the neck and do the high ligation at the level of deep inguinal ring of the sac.
Okay. Fine. Great. So it should be word Apurva has high ligation. You should go beyond neck. Neck should not be left behind, which can be a potential source of obstruction later. You understand? So that is the another point you said. So another question, if you find a large indirect hernia, how will you tackle it? Reaching up to the base of scrotum.
On the large indirect hernia, there may be due to there is a multiple adhesion is present in that case. We have to separate the
Completely reducible large indirect hernia.
We have to do herniotomy, and after
How will you do herniotomy?
After separation of the sac from the spermatic cord, location, sir, the distal part is left in situ, and
so it you transact near the superficial ring.
Yeah.
You understand? Leave behind the distal tag. That is important. So that's why it is important to know between complete hernia and incomplete hernia. If it is an incomplete hernia, you can remove from the fundus. But if it is a complete hernia or congenital variant, you have to transact the sac and leave behind. What care you will take while leaving behind that sac? It should be wide cap, left wide mouth. Do not ligate. Otherwise, you will end up with
feature of obstruction or there is
अरे distal sac ની વાત કરે છે.
સ્ટોમા ક્યાં obstruction થવાનું બેટા?
Distal sac ની વાત કરે છે.
Hydrocele can develop due to
hydrocele of hernia sac. So be careful about that. And how will you tackle direct hernia?
In case of direct hernia, we reduce the hernia, and posterior wall plication is done along with the wall of the hernial sac.
So what is made of posterior wall is made of what?
It is made of fascia transversalis.
So which part you suture with what? Upper border of fascia transversalis is sutured with the lower border of fascia. Remember, do not use conjoint tendon. Otherwise, it will become Basini repair.
Yes.
Right?
Yes.
So what is known as the lower part of fascia transversalis?
Lower part of it is
You do not suture with inguinal ligament. Again, lower part.
Yes.
If you suture with inguinal ligament, it becomes again Basini with iliopubic tract.
Iliopubic tract, yes.
Known as a Thompson's ligament. You suture with that. You understand? Another simple question. Can you perform preperitoneal mesh plastic by open method?
Yes, sir. We can go through the reef stopas repair. And
No. From inguinal region. I am not talking of reef stopas. In reef stopas, you do not open the canal. Single side. It is usually for bilateral. You go for reef stopas.
In Prolin hernia system, we do the people.
So that is one technique, but that has come basically because Sahib project question હતો એ preperitoneal hernia.
Can you do it or not? That is the point I want to know. And if you do it, what is that known as? There are certain surgeons who do preperitoneal repair from inguinal incision. Gunwant Rathod is one of them. He always does that way. So what you do, instead of plication, you cut the fascia transversalis and create a preperitoneal space.
Yes.
Then you enter the classical, what is known as the reef stopa space, and put a mesh there. That is the one method. Another method is known as McVay repair. What is that? And what is the advantage of that?
Okay.
This repair has a definite advantage. What is that?
In the McVay repairs, it is the transverse, that is abdominis, is fixed to the Cooper's ligament medially, and up to it is laterally it is transverse fixed to the iliopubic tract. It has advantage that is extend from the femoral sheath to the deep inguinal ring. So we can also.
So that is a must. The advantage of tackling femoral hernia.
Femoral hernia can be.
Your standard inguinal hernia repair won't work there. So this approach in book is known as a Lothian approach. When you put an incision on fascia transversalis in posterior wall of inguinal canal, enter the preperitoneal space, find out the Cooper's ligament, go behind the conjoint tendon in a preperitoneal space and join the Cooper's ligament, mesh at the Cooper's ligament and upper part inside the conjoint tendon rather than anterior to it, goes posterior to conjoint tendon. So that is another repair you should keep in mind, particularly when you are facing the femoral hernia. There is one more question. If you are in doubt whether it is a obstructed hernia comes and whether you are in doubt whether it is a femoral hernia or inguinal hernia, what will you do?
We can see the location of the
location જોઈને ખબર પડી જતી હોત તો બધા સર્જન થઈ ગયા. મને આજે હજુ નથી ખબર પડતી. Many times, even today I am unable to identify location ની ક્યાં વાત કરે તું?
Don't know, sir.
Simple. Go by inguinal approach, do the Lothian procedure. So that is the advantage of that. You enter that. If it is an inguinal hernia, you will easily tackle it. If you find it is femoral hernia, convert it into Lothian approach. So inguinal approach is the best for that. Or in sometimes we go for a McEvedy or a midline incision and enter the Reeves Topa space and create it. That is the advantage you should know in emergency. So what is the difference in a plan open surgery of hernia and emergency? When patient comes with obstructed or strangulated hernia, what will be the difference?
In the open elective, we do the mesh repair. Where in the open emergency scenario, mesh repair is not done.
Not necessary. Wrong answer.
The approach. What is the difference in approach of doing the surgery? See, unless you open the bowel, even nowadays, even after opening the bowel, people do put in mesh with good antibiotics and everything, but that might be the criteria if you are talking about resection anastomosis. Otherwise, in all patients, mesh nowadays, I think, is mandatory.
So unless there is RA, then it is again, I still put in RA sometimes. But yes, depends upon case. But in obstructed hernia, when the no resection is done, we always put a mesh. My question was not that. What will be the difference in approach?
We can...
again.
Sorry.
Stop this. All residents, stop heading. You can, we can is not the answer. I will do this, or we should do this, or we do this, like that.
I will go for a midline approach in the obstructed.
Again a wrong answer. Again a wrong answer. Never ever say that. It is always local approach. In a rare circumstances, if bowel is reduced and you are not sure of your pathology, then only. But always local approach. Out of 199 times it works. Very rarely you need a laparotomy. So never say laparotomy. Wrong answer.
No, sir.
The approach difference is that larger incision. Incision extending over the scrotum. Right? Second point is do not open the inguinal canal first. So do not put incision on external oblique. First, open the sac which is outside the external oblique. Why?
Because there can be spillage of the content or
content now, beta. It is fluid.
Toxic fluid.
Toxic fluid should be aspirated. One. Second point.
And if inguinal canal, the content can get reduced due to
very good. So do not remove obstructing site. First, open the sac, get hold of the content, then only proceed to relieve the obstruction. Otherwise, the content will go inside before you can assess them, and the gangrenous part you may miss, and then you need to convert to laparotomy. Do you understand? So always approach is, in this case, no dissection first. First, opening the sac, securing the content, and sucking away all the toxic fluid which may be hemorrhagic, and then go further. So that is the difference between plan approach and emergency approach. I think this should be more than sufficient, Apurva. We can
right,
go.
Sir. No, we have covered.
We have not discussed I think complications, but we'll leave it for something.
Yes, sir. Vinit bhai?
Yes, thank you, sir. Thank you so much.
नहीं नहीं, आपको कुछ पूछना बाकी रह गया?
No, sir. बस,
આજે બહુ થઈ ગયો હવે. This is thank you. Okay.
Thank you, sir. Thank you, sir.
Thank you, everybody.
Thank you.
Thank you.
Thank you, sir.
Smit, well done.
Thank you, sir.